The following is a paid program. WOR's airing of this program constitutes neither an endorsement of the products offered or the ideas expressed.
Welcome, everybody. It's the Radiosurgery Show with Dr. Gil Lederman, MD, New York's only Harvard-trained, triple board-certified radiation oncologist who brings you the latest cancer treatment news, interviewing world-renowned cancer experts, delving to special cases, and, of course, answering your questions. I'm Rob Redstone, broadcasting from the WOR studios in the heart of New York City. And now, please welcome Dr. Lederman.
Hello, good morning. I'm here with Daryush Nurbaha, who's my co-host today, and we have Eddie and Reggie in the technical aspects of the studio running this program, so we thank them. We're broadcasting live, so you're welcome to call in your questions. How are you today, Daryush?
Good morning, Dr. Lederman. It's a pleasure to be here.
Well, there's lots of news. We have lots of new cancer and medical news to talk about today. We also have some callers who called in after last week's show. We have two shows on WOR, one from 6 to 7 and one from 9 to 10. And some people are bashful to call during the show, and yet they're not bashful to call after the show, which is great. And we're going to talk about their questions. First of all, there's a new immunology study. So many people are interested in immunology, one special medicine that makes all the cancers supposedly go away. And, of course, doctors are working on that, and there was a report at the national cancer meetings, which were held this year. The meeting's called ASCO. And at ASCO, there was an antibody that targets programmed death. It's called PD-L1, and this is supposed to unleash the body's immune system.
PD-L1, it's like a gene or something?
PD-L1, yes. It's a programmed death. The antibody is supposed to program the death of cells and cause the body's immune system to take after cancer. So there's a preliminary study for people with solid cancers. It's a phase 1 study. Phase 1 means it was never done before.
Right.
And they took on patients with a variety of different kinds of cancers, like melanoma, colon cancer, rectal cancer, stomach cancer, kidney cancer.
Okay.
And they had some responses, and there was no overwhelming toxicity, so they felt that it was a favorable study. And the agent is called MPDL3280A.
That's a catchy name, huh?
Right. It's probably going to be changed if they're going to make oodles of money, I imagine.
Yeah, I hope so.
And it's given intravenously, so into the vein with a shot every 3 weeks to people with metastatic cancer. And then they tried to evaluate responses with CAT scans. And the CAT scans were done every 6 weeks for 6 months and then every 12 weeks.
Okay, so what were the results?
So there were 171 patients who were treated, and 43%, so almost half of them had some kind of adverse reactions that were called grade 3 or grade 4. The most common were high blood sugar or fatigue or abnormal enzyme levels in the blood tests.
Okay.
The results as far as cancer, so they had 171 patients, but only 141 were evaluable. So I don't know if people didn't get their CAT scans or they didn't show up or they weren't around to show up. We don't know that. They don't say.
They lost them.
But in 29 patients of the 140 who were evaluable, that's 21%, there was some tumor shrinkage.
Okay. Well, I mean, that's not a great percentage, though, is it?
Well, it's an early study. Phase 1 means it's never been done before.
Okay.
So you don't know if it's the right dose, wrong dose.
Right.
And they also didn't compare it. You know, first in America, the first evaluation is phase 1. If there's promise to a drug or an agent, then it goes to phase 2 to get better dosing. And then if there's still promise, it goes to phase 3, where it's randomized to either the best treatment known or no treatment versus the new treatment.
Okay.
Because you have 21%, maybe that's the placebo effect. We don't know.
Right.
So it's viewed as promising.
That's good.
The tumors that were involved, as I said before, include lung cancer, melanoma, colorectal cancer, stomach and kidney cancer. And the highest response rates were in non-small cell lung cancer. So non-small cell was the major form of lung cancer,
right.
and in melanoma. And of the responders, of the 29 responders, 26 were still responding at the time of their last assessment. And the responders were on treatment from 3 to 15 months. So it's a study out there that suggests there's new treatments for people with cancer, and that you shouldn't give up, even if you have metastatic cancer, and even if your prior treatment didn't work, there may still be other options out there. And we're here on this program to provide news. Someone called me last week and they said, well, why don't you do an infomercial and tell us more about what you do? And I told him we're trying not to do this as a commercial. I'm not trying to sell something.
Right.
I'm trying to update people with new information so that you can go out and tell your loved ones or yourself or your doctors, hey, I heard this. Does it apply to me? Or let me read the study. Let me investigate myself.
That's right. We're trying to have a dialogue with people that have concerns. And if they have any concerns during the show, they can call 800-321-0710. Or during the week, they can call 212-CHOICES for more information.
Right. So we try to answer everyone's question and try to do it in a reasonable way and try not to sell anything. So I apologize, but we're not selling anything today. There's another study out that looked at tamoxifen. Tamoxifen is a hormone that's used for many women with breast cancer.
Right.
We talked about it a few weeks ago. Well, there's another study.
Oh, really?
Another study talks about 5 years versus 10 years of tamoxifen.
Oh, okay.
So the question is, of course, what gives the woman with breast cancer the best chance of being alive, cancer-free? And we have another study, this one from Great Britain, that shows that 10 years of adjuvant tamoxifen. Adjuvant means, do you know what adjuvant means?
I have no idea.
Adjuvant means you're given something even though there's no known cancers. It's not like there's a ball of cancer in the lungs. No, the woman had breast cancer, and you're giving additional therapy to try to reduce the rate of recurrence of the cancer. That's
right.
what adjuvant means.
And that can be toxic to the
Everything
to the
can be toxic.
Okay.
Everything you give to the body theoretically can be toxic. So this study looks at it. It was a phase 3 study, and it looked at 5 years versus 10 years of tamoxifen. Again, it was presented at the ASCO meeting, and studies had shown that 5 years of tamoxifen reduced the risk of breast cancer recurrence and mortality by 1/3.
That's great.
Okay? So we know that 5 years is better than no tamoxifen.
Mm-hmm.
The question is 10 years better than 5 years? And this is a drug that's been out there for 30 years. So it's taken now 30 years or more to come up with a study to see if you can give it better than you used to. So doctors aren't necessarily omnipotent. We have to study things, and this is the reason for protocols, that some protocols lead to something that's really beneficial. And this is one of those protocols that seems to be very beneficial.
Right.
So for patients who had the 10 years of tamoxifen, the reduction in mortality and recurrence actually is starting to be seen after the 7th year. So it took 7 years just to start to see a difference. You can imagine you have hundreds of women for years and years of treatment. And in fact, the 10 years of tamoxifen led to a 24% reduction in mortality. So there were 24% less deaths from cancer in the women that took it 10 years versus 5 years.
Oh, wow.
So it's a significant reduction in mortality.
Now, I'm thinking about last week we were talking about taking estrogen. And what do you think about combining the estrogen with the tamoxifen for 10 years?
Well, it's like hitting your head against the wall. Estrogen is thought to stimulate the cancer.
Right.
Tamoxifen is out there as an anti-estrogen.
Okay.
So if you combine the two, you're going to end up with big troubles.
Okay.
So you do not want to do that. And any listeners, you do not want to do that. You speak to your doctor. Talk to them about the 10 years of tamoxifen. In the follow-up of this study, there were 580 recurrences in the women who had taken tamoxifen. for 10 years. And if you took it for a shorter period of time, there were 672. So it started out as an equal number. So if you took 10 years of tamoxifen, you reduced the rate of recurrence by about a quarter. And also, if you took 10 years of tamoxifen, there were 392 breast cancer deaths compared to 443 if you only took it for 5 years. So it's true that you really got scientific data that's analyzed in a serious way. And I want to make that information very clear that what we present on this show is true scientific data that's published in peer-reviewed journals. It's not some cockamamie idea, and there's no data.
What journal is that from?
This was at ASCO, actually. This was presented at ASCO.
Okay.
And ASCO is a major cancer group in America. And in fact, many oncologists from around the world belong to ASCO. We had several callers this week. One who asked about prostate cancer and proton beam, because there's a big push right now. There's new proton beam facilities. Proton is a form of radiation. Proton is the positive particle in an atom. Do you remember that from chemistry?
Absolutely. And electrons, the negative part. Right?
And remember, electrons are circulating around the nucleus.
They're in the orbits.
And protons are where? Do you remember?
In the center, right with the neutrons.
Right. So in the center of the protons and neutrons. So can you imagine there's now a way to get those protons out of the atom and bombard cancers with them?
That's pretty fascinating.
Right. So what you learned in high school chemistry has application. And people are pushing, some people are pushing to use proton for prostate and other cancers.
What's the advantage of proton radiation versus X-ray radiation?
Well, that's a great question. So the advantage is that protons have a more limited travel in the body. So people are saying, oh, if you radiate with protons, it has an entrance dose, but not an exit dose. It stops at a certain period. So
what if the cancer is deep inside the body?
Well, part of the problem with proton beam is exactly how do you calculate that? And many doctors that I know about talk about the uncertainty about where to stop the beam, because if they stop the beam too short, then cancer is left untreated. Cancer left untreated can be recurrent and be fatal.
Keeps growing.
Yeah. So anyway, this gentleman asked, well, why don't you talk about proton beam and versus what you do? And I'm happy to do that. In fact, if people call into us and get our prostate book, we'll mail it to you and for free. And on page 16 is comparison data of our results treating prostate cancer in our unique way with proton beam at one of the longest established facilities in America. There's a Gleason score in prostate cancer. So for men who have prostate cancer, they get a biopsy, and in two areas, pathologists look at the cancer under the microscope and they give it a number. 1 is the best number, 5 is the worst number, and then they add it up. Yeah. So the best you can have is 1 + 1 = 2. The worst you can have is a Gleason score, 5 + 5 = 10.
It's basic arithmetic, yeah.
And the most common is Gleason 6, 3 + 3 = 6. So in America, about 45% of men with prostate cancer have a Gleason 6. Okay. So if you look at Gleason 6 and Gleason 7, which is how the proton beam facility categorized their results, so the chance of being cancer-free with proton beam 5 years out with Gleason 6 and 7, do you have any idea what the number would be? Cancer-free.
40%?
It was 76%.
Oh, that's pretty
76% of men were cancer-free. Yeah. Our results, the same category, same patients, same category, 87%.
Wow.
So we had 14% more men cancer-free. You had a better chance of being cancer-free with us than with proton beam. So that's what I told the man who called me, that look at the data, you're better off with us than proton beam.
Yeah. So then at least definitely for prostate cancer, it seems that radiosurgery would be better than proton.
That's the data. I mean, there's the data. It's, we had thousands of patients. They had many patients. We compared our patients head to head in our facility versus their facility, and we had better results. Also, there's a whole issue about the cost. proton beam is very costly.
Really?
And